Hello and welcome to this video. My name's Kris. I'm an Australian GP and today's topic's a little controversial. Again, I'm so sorry. And I promise you I'm not making this to ruffle feathers. I'm making this video to raise awareness about what's happening in my corner of the woods, or my neck of the woods, as it were. There is a pilot study being proposed here in Far North Queensland, wherein the government wants to provide pharmacies with the ability to diagnose and treat up to 23 chronic health conditions. These conditions include gastroesophageal reflux, asthma, COPD, high blood pressure, high cholesterol, psoriasis, acne, type 2 diabetes, weight management, prescribing the oral contraceptive pill, treating urinary tract infections, and prescribing travel medicines. Just to reiterate, pharmacists are now looking at being able to diagnose, prescribe, and then dispense the medications, all in one go. For these extra 23 conditions, they only need, apparently, 120 extra hours of study. Full time, that's only 3 extra weeks. 3 weeks to be an expert in these conditions. Now, pharmacists are incredible. I could not do my job without pharmacists. I think pharmacists are an invaluable part of the community multidisciplinary team, and without them, our patients would suffer. I do genuinely believe that our pharmacists are fantastic, well-educated, intelligent, and invaluable colleagues. However, they are not doctors. And that's not to say that doctors are better than pharmacists. We're not better than anyone. We all have a role. In fact, most, if not all of my frustration is not even towards pharmacists, it's the pharmacy guild. As doctors, we spend a minimum of 6 years at university. We study the intricacies of how to communicate with patients, how to make a diagnosis, what the pathology, the pathophysiology, the common outcomes of several, more than 23 health conditions are. We learn to be diagnosticians, prescribers, and doctors in general. Then we spend at least a year in internship. This is when we are very heavily supervised by other doctors, honing our skills in communication, being able to diagnose, and being able to prescribe and treat. We also improve our skills in procedural things like suturing. Our clinical judgment and clinical reasoning increases in this time, as does our bedside manner. Next, we spend a year, but quite often more, as a resident. So as a junior doctor, we are again honing our skills in diagnosing, prescribing, bedside manner, communication, not only just with patients, but with other members of the team, including doctors, pharmacists, physios, OTs, social workers, and so on. Then we choose a specialty. In my case, I chose general practice, and this took me an extra 2 years of specialty training to achieve. I also had to sit 3 difficult, not to mention expensive, exams to get to where I am today. I spent 10 years getting to this point, and I got through fast. This is the bare minimum. Pharmacists, on the other hand, spend, on average, 4 years at university. And trust me, I'm not downplaying that, that's a long time. They learn a lot about the body and its intricacies, and pharmacology, and how the body reacts to certain medications, how it's metabolized, how drugs work, and how they interact with one another. They are specialists in pharmacology and pharmacy, as the name would suggest. But to say that 4 years and then 120 extra hours is the equivalent of a minimum of 10 years to get to where I am now as a GP, it just seems asinine. 3 extra weeks of training to diagnose, to prescribe, and to dispense. I do appreciate that this 120 hours is not a 3-week block. It's over 12 to 16 months, but it's still only 3 extra weeks of study. It's 3 extra weeks to add to their already increasing workload. And I don't say that to be condescending. Everyone in healthcare at the moment is under the pump. The last time I went to a pharmacy, which I will actually talk about in a second, I saw the pharmacists run off their feet. There were dozens of people in the pharmacy. It was busy. And to think that now we're adding to that. Again, I know that that may come across as condescending, and that is not my intention at all. So let's start with the diagnostic issue. Pharmacists will not be able to investigate, at least not with Medicare funding. So anything they order, if they are able to order, which, as a side note, We've been told of this trial, but we've not been told about the intricacies of this trial and what it's going to pertain. We've been told essentially nothing. And that's part of the frustration. Where is the safety netting? Anyway, it's fine, whatever, we'll get there. So let's go back to investigations. If a pharmacist can investigate based on this trial, it will come at an out-of-pocket cost for the patient. Medicare will not cover any investigations. So let's assume they can't investigate, or a patient doesn't want to be investigated because of the cost associated. Pharmacists will not be able to do spirometry to diagnose your asthma or COPD. They will not be able to swab your wound to ensure that your impetigo is not a resistant strain to the common antibiotics. They will not be able to send off your urine to find out if you truly have a UTI and if that's an antibiotic resistant one. They will not be able to order an X-ray or a CT or an MRI to see if your injury is truly just a sprain or if there is something else going on. A pharmacist will not be able to organise blood tests to check your sugars and your cholesterol to see if your treatment is on track, if we need to increase dose, decrease dose. And if they can investigate, like I said, it's going to be expensive. And there has been no talk about how they are going to look at their results, how they are going to recall patients. There's also been no discussion about how they will notify their regular GP, because if we don't know that you're on something, and not every patient will say, oh, the pharmacist prescribed me this, then what if we give you something that interacts with that drug? What if the pharmacist doesn't know every medication we've prescribed? There is a real fragmentation of care there. So let's talk about prescribing. Trust me, there is no such thing as just a script. I rarely have just a script consults. Every script comes with questions. How are you going on this medication? Do you have side effects? Are we reaching our target? Is it interacting with anything? Should we be decreasing this? Do you need to be on this prescription anymore? Even a simple pill script for the contraceptive pill includes a review of your blood pressure, a discussion about your sexual practices, a discussion about cervical screening, a discussion about fertility management, a discussion about long-acting reversible contraceptives. Is the pill the right thing for you, essentially? We talk about STI screening. We talk about safe practices. That's not just a script. It's never just a script. Now, let me remind you, pharmacists will absolutely know what medications are indicated for what conditions, at what doses, and what interacts with one another. I am not taking that away from them at all. I really do appreciate that that's their specialty. I don't think, however, pharmacists need to be GPs. That's what GPs are for. So they prescribe and then they give you that medication. In that interaction, they are missing a crucial role of having someone double check what's going on. I'm not saying that because I think pharmacists are going to make more mistakes than doctors. Not at all. However, having that person there to double check is a vital part of patient safety. When I prescribe something, I give the patient the script, they give it to the pharmacist who will look at it, and if they've got questions because something doesn't seem right, they will call me and we will have a discussion about it, and then we will amend it or we will discuss why I'm doing what I'm doing, and we will go on from there. That is patient safety netting. It is vital. And where is that going to be when the pharmacist is the diagnostician, the prescriber, and the dispenser? How are they going to follow all this up? How are they going to make sure that the patient has recovered from their illness? It gets worse when we talk about our remote communities. A simple ear infection, otitis media, in an Aboriginal or Torres Strait Islander child is not simply fixed with drops. There are follow-ups because we know there is an increased incidence of hearing loss in these patients. It's complex and it needs a really intricate follow-up. So where's that going to be? I also don't think that most retail pharmacies have the space to do this. So I've got a personal story to tell. I went and saw my GP several months ago now because I was having just a general checkup, and we found out that I had symptomatic candida. Basically, I had thrush, and this was diagnosed on a swab. Because I'm a GP and my GP is a GP, we had the discussion that I didn't need a script because I knew what to ask for and the medication was available over the counter, and we just saved the paper and I knew what to ask for. So I get to the pharmacy and the pharmacy tech asked me to come up there. Mind you, there's a couple of people to my left, a couple of people to my right, and a few behind me. It's a crowded pharmacy. She goes, "What can I do for you?" And I say, "I'd like clotrimazole 10%, please, the pessary." And she goes, "What?" I'm like, clotrimazole. She goes, "What's that?" I said, "Canesten?" And she goes, "Okay." Then she asked me very loudly in front of all these patrons, "So I take it you've got thrush then?" Like in a really condescending way too, which, no. I obviously said yes, but if I was another woman, I would have died on the spot. I would have been mortified. My private health information was just shouted across this pharmacy. Mind you, I'm also airing it on the internet, but that's neither here nor there. I was never asked if I wanted to step aside, if this was something that I'd like to talk to the pharmacist about at that point. It was just shouted across the counter. And this is not a one-off. I've had this experience at other times too. Then, as she was writing my name on it to hand to the pharmacy, she goes, "So why do you have thrush?" I mean, the answer is because I own a vagina and I'm nearly 30, and it's not uncommon for people around 30 to get a thrush infection at some point. There was no predisposing issue. But again, not her role. She's the pharmacy tech. And it was really, again, I kind of don't care, but it would have been humiliating. In fact, it was. I just don't care. So anyway, she took the medication, she gave it to the pharmacist, and I was moved along to another counter. At this counter, the pharmacist then came over with the medication and confirmed it was for me. And then she said, "So, have you got thrush?" I said, "Yes." And she said, "Have you been on antibiotics recently?" Which is actually a really good question. I'm so thankful she asked. The answer is no, but I can see why she was asking. And then her next question was, "So do you want probiotics? Because we've got insert brand here." And I went, what? There was no discussion about, is this your first time? Is it not? There was no discussion about the causes of thrush. There was no discussion about my other medications. There was no discussion about anything. It was just an upsell. And for the record, probiotics, especially with a one-off infection, they don't do anything. In rat studies they may, but I don't have a rat vagina. Well, that sounds weird. But yeah, it was just this most bizarre thing. And that one interaction gives me so much fear for if this pilot goes ahead. My fear, and let me just make it clear again, I don't think every pharmacist will do this, is that every prescription will come with an upsell. Because it may be a little known fact, but pharmacies don't make a lot of money out of prescriptions. They make all their profits, or at least the vast majority of their profits, from the retail stuff they sell. That's why pharmacies have perfumes and makeup and vitamins and minerals and hair care and even laundry detergent and tissues. That's where they make their profits. But my fear is someone will be diagnosed, maybe correctly, maybe incorrectly, with diabetes. The pharmacist will then say, well, metformin's first line, so you start metformin. But metformin has a really common side effect of diarrhea. So here's some gastro stuff if it gets annoying. But if you still have diarrhea, you might be replete in your electrolytes. So here's some hydrolyte for you. And also, having type 2 diabetes decreases your immune system. So here is a bogus immune booster for you, just to make sure you don't get sick because of your diabetes. Suddenly, one diagnosis has 5 things being sold. It's very cynical of me, I know. And I'm not saying every pharmacy will do this, nor will every pharmacist, but it's a fear of mine. Have I mentioned, by the way, that each consult will cost $55 with no rebate? My out-of-pocket for my 10 years of training is $47, so it is more expensive to see a pharmacist than it is a GP. The Pharmacy Guild have described this as a turf war. It's not a turf war, it's about patient safety. The Pharmacy Guild have described that this is to fill the gap of the lack of GPs in Far North Queensland and how long it takes to get an appointment. Well, instead of training up pharmacists, why don't we get more GPs up here? Trust me, we have a lot of ideas. This will not strengthen the system. It will shatter the system. This was an election promise from the government. And I won't go into too much detail about that because I could be here for another 17 minutes. Most of the main political bodies and the pilot bodies, like the RACGP and the AMA, have pulled out of this trial because of how dangerous it is. A colleague of mine was a pharmacist before he became a GP. In his words, most pharmacists are ignorant of their ignorance, and they don't know what they don't know. Overall, I have many, many concerns. Most, if not all of these concerns are echoed by my colleagues, by my college, by several pharmacists. There are holes in the healthcare system, I don't deny you that, but this is not one way to fill them. So that's my rant. I just wanted to give a little bit of context as to what's going on in my neck of the woods, and knowledge is power, and now you've got to know a little bit more about what's going on. So until next time, guys, do stay safe, stay healthy, and I'll see you in a video very soon.